Welcome everyone to tonight's lecture. We are going to be reviewing some ENT disorders tonight. So make sure you set your lecture note up on your paper the same way we've done in the past, where we're going to be reviewing different things with a description, etiology, incidence rate, risk factors, assessment findings, differential diagnosis, diagnostic studies, prevention, non-pharmacological and pharmacological management, as well as consultations, follow-ups, expected course, and possible complications. But first, I want to talk about otitis media. We're going to talk about some common things you're going to see in your primary care practice because that is what you are here to learn is family nurse practitioner. So otitis media, there's two different types. There is acute otitis media, written as AOM, and that's a rapid onset of signs and symptoms of inflammation in the middle ear. Otitis media with effusion, OME, is a fluid accumulation in the middle ear without evidence of an infection. It could be also called a middle ear effusion. Otitis media with effusion can occur as a result of an episode of otitis media or eustachian tube dysfunction, and it could precede or predispose someone to get otitis media. So etiology, for acute otitis media, it's bacteria and viruses. Viruses can be anywhere from 15 to 44% of your cases. Other common are your Streptococcus pneumoniae, which is about 20 to 35%. Haemophilus influenzae, 20 to 30%. Group A beta hemolytic strep, about 15%. And Staph aureus, around 12%. Otitis media with effusion is probable due to incomplete resolution of an AOM, or there is a eustachian tube obstruction. Incidence rate, more common in the winter months, most common in children 6 months to 3 years old. Lowest incidence is actually in breastfed babies. Risk factors, daycare attendance, craniofacial abnormalities, upper respiratory infection, allergic rhinitis, secondhand cigarette smoke, first episode of an AOM less than 12 months old, bottle feeding while in a supine position. Assessment findings for acute otitis media, moderate or severe otalgia, so tugging, pulling, rubbing of the ear, irritability, intense erythema of the tympanic membrane, decreased tympanic membrane mobility. So when we're looking through the otoscope, you're going to see that. We're going to have distorted landmarks, displaced light reflex, cloudy, dull, or opaque TMs, moderate to severe bulging TMs, temperature greater than 102.2 degrees Fahrenheit. You got GI symptoms, nausea, vomiting, diminished hearing, dizziness. And when we have otitis media with infusion, it's usually asymptomatic. They have a very dull tympanic membrane. It's decreased mobility. There's visible air fluid interface or visible air bubbles, and there's diminished hearing. So acute otitis media is a sudden onset of ear pain with middle ear effusion, erythema with moderate to severe bulging of the TM, or a new onset of otorrhea not caused by otitis externa. AOM is usually accompanied by signs and symptoms of local or systemic illness. Differential diagnosis is otitis externa. They also can go hand in hand. We could also have a tympanic membrane rupture. There could be tumors, or this could be referred pain from the jaw or teeth. Crying may cause tympanic membranes to appear red on examination. Diagnostic studies. You're going to look in the ear. We're going to measure TM compliance, and we're going to consider referrals to obtain a culture if needed, but that's rarely, really ever done in primary care practice. Prevention, breastfeeding, avoiding cigarette smoke exposure. Do not put the baby to sleep in a horizontal position with a bottle. Increased use of the pneumococcal conjugate vaccine 7, the PCV7, can help with preventing these AOMs. Increased use of the influenza vaccine, reducing or eliminating pacifier use in the second 6 months of life. Prophylactic antibiotics should not be prescribed to reduce the frequency of AOM in children who have recurrent AOM. So non-pharmacological management, local heat, swallowing to help the eustachian tube ventilate, and patient and family education regarding treatment, disease, and comfort measures. Pharmacological management, antibiotics do not relieve pain in the first 24 hours. So we're also going to give this patient oral analgesics, mild to moderate. We can do acetaminophen or ibuprofen, depending on the age. If they have severe pain, they could theoretically get something that might have codeine in it. We have topical analgesics, benzocaine, procaine, lidocaine. There's also some naturopath, drops that are out there. And when we do the pharmacological management, the American Academy of Pediatrics encourages symptomatic treatment without antibiotics initially if the diagnosis of otitis media is unilateral and uncertain, or if there is a mild disease. We're looking at pain, less than 24 hours, temperature less than 102, the child 6 to 23 months of age. However, if a child worsens or fails to improve within 48 to 72 hours, antibiotic therapy should be initiated. Antibiotics should be prescribed for children 6 months and older with unilateral or bilateral otitis media that have moderate to severe symptoms for at least 24 hours. If antibiotics are used, the initial antibacterial agent for most children is amoxicillin if they do not have an allergy to penicillin. The starting dose of amoxicillin is recommended at 80 to 90 milligrams per kilo per day in divided doses. There's no antibiotics with specific approval for use in adults for otitis media. It seems reasonable that to use the same antibiotics for adults that we would use for children. Let's look at, so we got penicillin, pretty common, generic name, we know amoxicillin. For adults, we're going to do 875 milligrams, Q12 hours for 5 to 7 days. An alternate would be 1,000 to 2,000 milligrams, Q12 hours for 5 to 7 days, depending on your patient. Children, 80 to 90 milligrams per kilo per day in divided doses. Max should never exceed the adult dose. If they're less than 2 months of age, it's 30 milligrams per kilo per day in divided doses. Amoxicillin is not as stable in the presence of beta-lactamase producing organisms. Considered the first-line agent in most cases unless the patient has had antibiotic exposure in the last 90 days. So it's always important that we do those health histories. Another drug could be Ceftonir. Adults, 300 milligrams, Q12 hours for 10 days. And for children, 6 months to 5 years, it's 14 milligrams per kilo every 12 hours daily for 10 days. If they are 6 to 12 years old, it's 14 milligrams per kilo, Q12 hours for 10 days, or 24 hours for 10 days with a max dose of 300 milligrams. So Ceftonir is a pregnancy category B. It is considered probably safe in lactation. We need to avoid antacids or iron 2 hours prior to or after taking Ceftonir because that will interfere with its absorption. And the stools may actually appear red if they take this antibiotic with iron supplements. Another one is Omniceft. You'll see that one written often, which is the trade name. Can come as a capsule of 300 milligrams. There's a suspension of 125 milligrams per 5 ml. We have Rocephin that comes as 250, 500, or 1 gram. We do not use in patients who have had hives or anaphylaxis to penicillin. There are extended spectrum macrolides, and these we use if we have no other drugs to give the person. So like azithromycin would be a good choice. Adults, it's 500 milligram daily for 3 days. Children, 6 months. We do 30 milligrams per kilo as a single dose, max of 1.5 grams. And name brand would be Zithromax. We also have clarithromycin in 200 to 500 milligrams Q12 hours for 7 to 14 days. Children, you're doing 15 milligrams per kilo per day in a divided Q12-hour dose for 10 days. Both of these are pregnancy. Oh, actually, I take that back. Zithromycin is a pregnancy class B, and clarithromycin is a pregnancy category C. And one of the things we should tell them also is taking these macrolides with food can help with any of the GI upset that those drugs can cause. Another one you probably are used to is augmentin, which is amoxicillin mixed with the clavulanate. And usual dose for adults is 875 milligram tablet every 12 hours for 10 days. There are some alternates, like a 500 milligram tablet Q12 for 10 days. Children 2 months to 5 years, we're doing 90 milligrams per kilo per day. If they are 6 years old to 12 years old, it is 90 milligrams per kilo per day as well. But we do divided doses. So that is our otitis media. Next on our list of ENT things to review is sinusitis. Acute rhinosinusitis, acute bacterial rhinosinusitis. Our description: inflammation of the paranasal sinuses due to bacteria, viral, fungal, or allergic reactions. Our etiology of acute sinusitis: if it's bacterial, it's mainly Streptococcus species, Haemophilus influenza, and Staphylococcus species. If it is viral, it is mainly rhinovirus, coronavirus, influenza A and B, parainfluenza virus, and respiratory syncytial virus. Chronic sinusitis is usually caused by gram-negative anaerobic organisms. The vast majority of cases of rhinosinusitis are due to viruses and not bacteria, and it is the persistence of symptoms that will suggest sinusitis. So incidence rate, common in all ages. Males have an equal rate of incidence to females, common in early fall and early spring. Risk factors: allergies, asthma, tooth abscesses. 25% of chronic sinusitis is actually due to a tooth abscess. Cigarette smoking, swimming in contaminated water, any condition which results in swollen nasal mucosal membranes, such as a common cold, allergic rhinitis, anatomical abnormalities which prevent normal mucosal drainage, such as nasal polyps or a deviated septum. Your assessment findings are going to be fever, nasal congestion or discharge, could be purulent, could be bloody. They're going to have a headache, a sore throat from persistent postnasal discharge, pain or pressure over the cheeks and the upper teeth, suggesting of maxillary sinus involvement. They're going to have pain and pressure and tenderness over the eyebrows. That is the frontal sinus involvement. Pain, pressure, tenderness behind and between the eyes. That's your ethmoid sinus involvement. They're going to have a cough. They're going to have halitosis, postnasal discharge, throat clearing, periorbital edema. Bacterial infection is more likely if the symptoms are greater than 10 days, worsening of symptoms after initial improvement, persistent purulent nasal discharge, fever, or a unilateral face or tooth pain. So our differential diagnosis: viral upper respiratory infection, allergic rhinitis, dental abscess, headaches, nasal foreign body. Diagnostic studies, CBC, elevated white blood cell count if there's a bacterial infection. If we can do some sinus x-rays, we're going to have opaque areas on the radiographs. If they get a CT scan, that's actually the most useful tool to evaluate recurrent sinusitis, but it's unable to differentiate between bacterial or viral. We can do transillumination, and we get that opaque air fluid levels if the sinus cavity is infected. We could do some allergy testing if we suspect that that is a possible trigger, and we can consider a culture and sensitivity for treatment-resistant infections. Now, prevention, we're going to promote drainage by avoiding irritants which increase pressure in the mucous membranes. We don't want we want blowing rather than sniffing. And the person should blow the nose instead of going like that. We want good hand washing, preventing those upper respiratory infections, and management of underlying allergies. Non-pharmacological management, avoiding environmental irritants like cigarette smoke. We can do saline irrigation. We can manage our allergic rhinitis, humidified air, irrigation of the sinuses with normal saline drops or spray, increasing our fluid intake to keep the mucus thinner. We want to sleep with the elevated head of bed so that we could aid with drainage. We want to do patient education regarding disease and different treatment options. Pharmacological management is antibiotics for acute infections and patients with moderate to severe infections. Current data supports watchful waiting of acute infections for 10 days. We can switch to an antibiotic with a beta-lactamase coverage if the first course of antibiotics is ineffective. In adults, 5 to 7 days of antibiotics are as effective as 10 to 14, and we get fewer side effects and more compliance. Decongestants is preferred over topicals. However, people can use that Afrin, but we don't want them using that more than 1 to 2 days because they can get rebound stuffiness. Analgesics for headaches, antipyretics for the fever, topical nasal steroids in conjunction with antibiotics is usually a good help. We want to there's a risk for resistance, and we should evaluate that prior to determining antibiotic therapy. Risk factors for resistance include ages under 2 years or over 65, recent antibiotic use, hospitalization within the last 5 days, presence of comorbid conditions, immunocompromised states. So let's look at pharmacological management. Antibiotics. Number 1, amoxicillin, penicillin. We could do an extended spectrum penicillin, which would be our Augmentin. We can do tetracyclines. There's doxycycline and vibramycin. There are cephalosporins that are 3rd generation, like your Ceftonir or Suprax. We have clindamycin. Name brand would be Cleocin. And then we have our macrolides like azithromycin. We can do quinolones like levofloxacin or Levaquin, but remember that we cannot give Levaquin in patients that have a QT interval issue, and we have to make sure that they are not taking dairy, multivitamins, or calcium-containing products while they are on Levaquin, and there's always a huge increase risk for getting a tendon rupture. There's moxifloxacin, also known as Avelox. That is a heavy hitter quinolone, so we tend to use that one as a last resort. We got pregnancy lactation considerations. Sinusitis may be aggravated by the actual physiological nasal congestion that occurs during pregnancy. A mild decongestant use is considered safe for short-term use. but hasn't really shown to be effective. Avoid antibiotics in the pregnant population unless absolutely necessary. We never give tetracyclines or quinolones during pregnancy or lactation. We can refer to an ENT if this person's getting recurrent infections or treatment-resistant infections, and consider immediate referral if the patient develops periorbital cellulitis. And always refer to emergency care if you are suspecting meningitis. Follow-up is indicated until clinically free of infection for unresolving or worsening symptoms after 3 to 5 days of antibiotic therapy. Expected course of treatment, there's a good prognosis for acute sinusitis. Chronic sinusitis frequently recurs unless the causative factor is treated. If it's allergies, if it's a drainage problem, we need to eliminate those issues for this to go away. The last disease we're going to, or disorder we're going to talk about for ENT for this lecture is vertigo. That is a sensation or an impression that an individual is moving or that objects around them are moving when no movement is occurring. It's a disturbance in the equilibratory apparatus with either peripheral or central causes. So peripheral etiologies are otogenic, Meniere's disease, infections of the inner ear, immune-mediated inner ear infections, otitis media, acute labyrinthitis, obstructed eustachian tubes. We could have a toxic etiology, excessive alcohol ingestion, solicitate use, diuretic use, ototoxic drugs like aminoglycosides. Could have an environmental etiology, noise or bright lights. There could be motion sickness. If we're looking at central etiologies, the most common cause is a migraine. Vestibular migraine can cause dizziness. There could be a circulatory issue, such as a transient ischemic attack or postural hypotension. Neurological etiologies, multiple sclerosis, temporal lobe seizures, cervical vertebrae disorder, syphilis can cause this, demyelination, acoustic tumors in that eighth cranial nerve, or a brainstem or cerebellar vascular lesion, and other things that can cause vertigo is hypothyroidism and psychiatric illnesses. More than 90% of patients with vertigo will have a peripheral cause. Elderly patients are more likely to have a central etiology. So our incidence rate. Overall incidence of dizziness, vertigo, and imbalance is about 5 to 10%. It can reach 40% in patients greater than 40 years old, but it's usually seen in the 20 to 60-year-old. Risk factors, history of migraines, cardiovascular disease, anxiety, depression, stress, 60 years of age or older, imbalance as the chief complaint. We want to assess risk factors for migraines, cardiovascular disease, and exposure to toxins. Assessment findings. All the following findings are possible, but it depends on the etiology. We could have asymptomatic except for vertigo. We could have nystagmus with extraocular movements. We could have tinnitus, or like ringing in the ears, hearing loss, ear pain, episodic attacks. We could have a carotid bruit. Persistent vertigo is usually a central cause. Headache, diplopia, and slurred speech is usually a central cause, and hypotension. So we need to differentiate peripheral from central. So let's look at the reflex, ocular motor reflex. If it's a peripheral reason, there's going to be spontaneous nystagmus with the eyes closed. If it's a central lesion, are going to have gaze evoked nystagmus. If we have vestibular ocular reflex, the VOR, then nystagmus without fixation, or nystagmus after head shaking. And if it's central, there's a failure of a fixation suppression. So assessment findings Most common in causes of vertigo, we have a thing called benign paroxysmal positional vertigo, BPPV. This is episodic vertigo lasting seconds. It's associated with body position changes. There's nystagmus, which shifts in the head position. Usually no hearing loss, no ringing in the ears, but we can get nausea and vomiting. We have vestibulopathy as vertigo with position change. It's episodic vertigo. It lasts for days, usually with nausea. Same, or is usually no hearing loss and no ringing in the ears. And it often follows gastrointestinal or upper respiratory infections. Then we have Meniere's disease, which is a sudden vertigo. It lasts for hours. There is ringing in the ears. There's hearing loss. There's a feeling of ear fullness. There's nausea. There's vomiting. Migraine, brain, or vascular disease. We get a sudden onset vertigo lasting a few minutes to up to 24 hours. They get diplopia, autonomic symptoms, nausea, dysarthragia, dysphagia. We get focal weaknesses. They usually have a history of migraine headaches, cerebellar disease. They get unable to ambulate during an attack. They get impaired ability to perform rapid alternating movements, and there's usually some gait ataxia. So differential diagnosis, vestibular disease. We got acoustic neuromas, cardiac and vascular pathologies, cerebral ischemic issues, sensory deficits, psychiatric illnesses, metabolic disorders, diabetes, syphilis, inner ear disorder, different diagnostic studies. We have to do a complete history. We need to do a neurological exam. We need to test cerebellar function. We have to assess our cranial nerves, especially cranial nerve 8. We need to observe presence of nystagmus. We have to do an ocular motor exam, and we need to do vestibular spinal reflexes. For hearing, we can do audiometry to discern hearing loss, the Rhine and the Weber's tests. For labs, we can do an H&H to rule out anemia, TSH, and a syphilis serology. Always consider fasting blood glucose levels to rule out diabetes. Cardiovascular, we want to do blood pressure checks in 3 positions, sitting, standing, lying. Bithermal caloric testing. We could do brainstem responses. Consider a CT or an MRI if we want to rule out central lesions. And we can do hyperventilation exam. Identifies hyperventilation syndrome, and that will accentuate central and vestibular dysfunction. Pharmacological management. So our goals of pharmacotherapy is relieving the vertigo, reducing morbidity, and preventing complications. And our treatment options depend on the etiology of the vertigo. Common things you're going to see written are antihistamines, meclizine, which is known as Antivert, promethazine or Phenergan, diphenhydramine or Dramamine. People can use the transderm scope patch that goes behind the ear. Vestibular suppressants are very limited use because they can mess with brain's natural compensatory mechanisms. We have anticholinergic agents, and they work centrally by suppressing conduction in the vestibular cerebral pathways. A transderm scope falls under that anticholinergic agent because that has an action where it antagonizes histamine and serotonin, so it's very effective for motion sickness. Antiviral meds are controversial. Antiemetics are given during the acute phase. Anxiolytics, benzos are indicated for anxiety and sedation, and age-appropriate dosing would be needed. If we're talking about Meniere's disease, they usually will do gentamicin drops into the tympanic membrane. We could do corticosteroids. That's a case-by-case use. It's age-appropriate dosing. Always do a taper. Some cases may improve long-term. So antihistamines, the diphenhydramine, also known as Dramamine, meclizine, can buy those over the counter. Antivert does come prescription. Consultations and referrals. Refer if neurological symptoms exist. Refer any problems that are disabling and or progressive. Refer for to a all ear, nose, and throat doctor for other or unknown etiologies. There are neuro-otologists for auditory and vestibular testing. Follow-up is dependent on the etiology and severity, and the expected course is dependent also on etiology, but generally peripheral causes have a better prognosis than central.